Welcome to the Pancreatic Cancer Action Network's webinar, Treatment Approaches for Pancreatic Adenocarcinoma, presented in recognition of National Pancreatic Cancer Clinical Trials Awareness Month. Founded in 1999, the Pancreatic Cancer Action Network is a nationwide network of supporters working together to advance research, support patients, and create hope for those affected by pancreatic cancer. For more information, please visit their website at pancan.org. This educational webinar is sponsored by Oncogenics Pharmaceuticals Incorporated. It is scheduled for 60 minutes and includes a presentation followed by a Q&A session. A recording of this presentation will be available on the Pancreatic Cancer Action Network's website under the Educational Events page. Now I would like to introduce you to our presenter. Dr. Varadhachary is a professor of medicine in the Department of Gastrointestinal Medicine Oncology at the University of Texas MD Anderson Cancer Center. She joined MD Anderson in 2003 and has pursued clinical and translational research in cancer of unknown primary and pancreatic cancer. Her research in pancreatic cancer includes the use and sequencing of pre-operative therapies in the management of resectable and borderline resectable cancer and use of novel agents for metastatic pancreatic cancer. Dr. Varadhachary has authorized and co-authored over 80 articles in peer-reviewed journals and authored many textbook chapters. Dr. Varadhachary is the medical director of the gastrointestinal cancer at MD Anderson and serves on several institutional committees. Dr. Varadhachary, I will turn the presentation over to you.
Thank you, Gerald. Hello, everybody. Over the next 45 minutes, I will share with you the treatment approaches for pancreatic adenocarcinoma. What I do want to state before I go into the details is that this is pancreatic adenocarcinoma that I will be discussing. Sometimes there's a bit of a confusion because pancreatic neuroendocrine cancers are also a part of the pancreatic cancers spectrum. So when we think of the pancreas, it's a fish-like organ about 6-8 inches long behind the stomach, and it has exocrine glands and endocrine glands. The exocrine component is the one that secretes pancreatic juices and is responsible for 90+% of the cancers that we refer to as pancreatic adenocarcinoma. So going ahead, the first thing I wanted to bring up is that pancreatic cancer is a systemic disease in most patients, and unfortunately, it's rarely curable. We see about 39,000 to 40,000 patients every year in the United States with new diagnosis. And to bring up simple statistics as to what is the survival of our patients, if you start with 100 patients with pancreatic adenocarcinoma, 15 to 20 patients will have resectable or operable disease. But unfortunately, most patients present with inoperable, either locally advanced or metastatic disease. And the 5-year survival is less than 5%. We are making progress, and even though in most patients the survival is measured in months, there is constantly new information coming out, which I will discuss today. So one other question that often comes up is that why is there no screening tests like we have for breast cancer or prostate cancer? And the issue here is that for most patients, the symptoms can be very nonspecific for months before we can put it all together. Given that the pancreas is tucked away behind the stomach, symptoms can be ulcer-like or a vague pain or weight loss. When jaundice sets in some patients, it becomes a clear red flag and one pursues additional studies. We do not have any good screening tests today for detection of early pancreatic cancer, though in patients with high-risk genetics, there are clinical trials and screening algorithms that are in place, and hopefully we can continue to make progress there. The staging of pancreatic cancer is very dependent on a good quality CT scan. I cannot emphasize enough how important it is to get a high-quality imaging study to really understand the tumor vessel orientation and any concern for spread. This is a busy slide, but just to give you a brief idea of what we mean when we discuss stages 1 through 4. Stage 1 and stage 1A and B are cancers that are small, could be in the head, which is shown in this cartoon, but it can be in the body of the pancreas or the tail of the pancreas. It's usually a small cancer not involving any of the vessels. This is my laser pointer, the red dot you see, which is on a vein, and the red next to it is the artery. So the tumor is not involving the vessels. It's not involving the duodenum. This is the C-like organ right here. Stage 2 and A and 2B cancers are larger, but they are again not involving the vessels. The vessels are clear. They could involve the lymph nodes around the pancreas. Stage 3 cancer is when the vessels are involved. These are important arteries and veins that supply the stomach and supply the liver and intestines. And when they get involved with cancer, whether it's partial involvement or complete encasement, it's technically very challenging to tease the tumor off the vessel. Stage 4 cancer is when the spread is out of the organ into the lungs or liver or lining of the bowel. So when we discuss the staging, the stage 1 and 2 are operable, and stages 3 and 4 are inoperable. And therefore, a high-quality CT scan helps us really understand what is the best option going forward in terms of sequencing therapies. As I mentioned earlier, it's a small group of patients who have operable cancer when we look at the first CAT scan on presentation. And besides the CT scan, we have additional tools. There's an endoscopic ultrasound, which is an ultrasound that is done through a scope, put through the mouth, into the stomach, and through the stomach wall, the ultrasound looks at the pancreas and the blood vessels. It can also help with the biopsy. With sophisticated imaging, as we discussed with new sophisticated scan approaches and endoscopic ultrasound, there is an emerging category called borderline operable cancer. It's a small group of patients, but when you look at a scan of such a patient, it's not clearly easily operable just looking at the scans, but it's not completely inoperable either. The vein or the artery may be nudged by the tumor. It's not encased by the cancer. And the question that comes up is, if we can give preoperative therapy, can we change that locally advanced or a borderline operable cancer to an operable cancer? So this new category of borderline operability is somewhere between stages 1 and 3. So this is what I'm talking about. As you can see right here, the clearly operable and the clearly inoperable, and you have this small group of patients. To orient you to what the scan is, it's an axial scan, so it's a cross-section looking at the body, CT scan. This is the liver right here, where my red dot is. This is the kidney, and this is just the head of the pancreas. Not easy to see, but again, this is a stomach filled with barium next to it. This ring-like thing is a metal stent. All this that my dot is showing here is a tumor. What you want to see in an operable cancer is a nice black ring of fat, as you can see all here around the kidney, a nice black ring around the vein and around the artery. But what we see instead is that the tumor is extending all the way back, and it's encircling this artery about 180 degrees. This is an important artery, and it's very difficult for a surgeon to scrape the tumor off this artery. If one proceeds with surgery right away, a rim of tumor is left around this artery, and it's really not helped the patient because it becomes a margin-positive surgery. The other thing we like to look at with CAT scans, and here it's obvious, but it's not always very obvious, is the liver okay? Because the pattern of spread could be to the liver, to the lungs. As you can see right here, these dots, this is concerning for cancer spread, or changes in the lining of the bowel, these lesions right here. So when the team looks at a CAT scan, not only are you looking at the primary tumor with its orientation to the vessels, but also very, very close look to the liver, to the lungs, and the lining of the bowel all the way down to the pelvis to make sure there is no small area of concern. For example, this small fluffy dot you see here, this could be the only lesion in the lining of the bowel that could raise a red flag that this is a stage 4 and not a stage 1 or 2 pancreatic cancer. So it's important to do very thorough staging right away on presentation. Now, the treatment options that are available, the approaches that are available include surgery, radiation, and chemotherapy. And I've divided this into the various stages that we have, and I've discussed briefly. The sequencing and the options that are available depends on the stage. For example, a patient with borderline resectable may get all 3 tools. We may use all 3 tools before a patient goes for surgery, not necessarily in the sequence. Patients with metastatic disease are not candidates for surgery, rarely for radiation, and the most important armamentarium is chemotherapy. But these are typically the 3 things we look at in terms of our therapy options. I will go through these based on the various stages. Let's start with resectable pancreatic cancer. Again, to show you a cross-section CT scan of an operable tumor. This is the liver right here. This is the pancreatic tumor in the head of the pancreas. This dot here that you see is actually a plastic stent for a patient who was jaundiced and has undergone biliary decompression. This is the vein called the SMV, superior mesenteric vein, and this is the artery, the superior mesenteric artery. Very clear fat plane around both, suggesting a clearly operable cancer. And in this patient, we also look at the liver and the rest of the abdomen. This is just one slice that I have shown you right here. So in such a patient, what are our therapy options? The standard of care is surgery. Because it's pancreas head tumor, it's pancreatic duodenectomy, which is the Whipple procedure. If the tumor is in the body or tail, the surgery is called subtotal pancreatectomy. I would like to share some facts. Yes, it is true that for most patients, we are concerned about recurrence, and the long-term survival is 20%. But what's most important is that one can improve the chances of cure by making sure that the surgery is done in a high-volume cancer center. Surgeons who do this on a regular basis. The recovery from such a surgery is a challenge and can take weeks. So it's really important that the team planning the surgery and doing this knows how to do vein and artery grafting if it's necessary. About 20 to 30% of patients do not receive postoperative adjuvant therapy, either based on just a slow recovery or a concern for spread or postoperative complications. So it is a very difficult abdominal surgery. The median survival is about 2 years. So the question is, how do you improve over and above surgery. And that's where the term adjuvant therapy comes in. Adjuvant as in adjunct to the definite plan, which was surgery. What else can we do to improve the chances of cure? One option is chemotherapy to kill any microscopic cancer that might be floating around in the blood or other organs. And the other is radiation, which is a bit controversial at this point. And the question is, do we concentrate on the tumor bed, on the surgical bed, especially if it's a good surgery, or should we really concentrate to prevent any distant disease? Some of the data that has come out from Europe has suggested that radiation's role may not be that important, but I think we need to still answer this question in select patients. So what is the status of post-operative adjuvant therapy for resected pancreatic cancer? These are patients who have undergone a good surgery. They have a clear margin. And what else can be done after completion of surgery? There have been many trials, and I really do not want to get into all the details on this busy slide, but I want to point out is that this first study was done in 1985, the first important study. And you go all the way down to the current decade. And what I notice is that in the last 20, 30 years, if you look at the observation arm, so these are patients who got some treatment, some adjuvant treatment after surgery, and this is a group that did not get any adjuvant therapy. They got only surgery. So the observation arm has shown significant improvement in survival, doubling of survival from almost a year to 2 years. And that is just based on good surgical care, ICU, antibiotics, and all the supportive options available to us today. Unfortunately, we've not made as much progress in the adjuvant setting. And that is because we need better drugs and we need better trial designs to really understand the impact of therapy in the adjuvant setting. The treatment today in the adjuvant setting for a resected pancreatic cancer is gemcitabine. This has been answered using 2 large studies. Gemcitabine was compared to observation in CONKO, and 5-FU, which is a very old drug, 5-fluorouracil, was compared to gemcitabine in ESPAC-3, which had 1,000+ patients. And the reference standard is gemcitabine given better tolerability, but 5-FU is also an option, and we do need to figure out which patient helps whom. And our patients need to get on to adjuvant therapy after surgery once they have adequate recovery. As I mentioned earlier, the role of radiation is controversial, and there are trials comparing chemotherapy to chemoradiation with an optimal design and tissue acquisition data. We hopefully will have more information of how we would like to proceed in the United States for patients getting surgery followed by chemo. In our center, patients who have a microscopic positive margin are offered radiation. We discuss this in our multidisciplinary meetings. We discuss how the surgery went, what did the scans show, how did the patient handle chemo, and then make a group decision between the surgeon, the medical oncologist, the radiation oncologist, the pathologists, and the radiologist who shows us the scans, and discuss the best option of adding or not adding radiation in the patient's care. So just to give you a flavor, resectable pancreatic cancer treatment is a multimodality treatment where different groups need to come together with their varied expertise. So to summarize adjuvant therapy for resectable pancreatic cancer, so far we know with all the studies done that some treatment is better than no treatment. And if our patients can handle some adjuvant therapy, that is good. But it's important that they've recovered adequately from surgery. But we need to work very hard and continue to make progress because it is quite embarrassing that we've really not done enough in the last 25 years. There are new trials that are being planned as I speak, and we are very excited with some new novel agents that will be brought to the adjuvant setting, and hopefully we will have much better differences and delta to show in the next 10 years. I want to just switch gear for the next 5-10 minutes and talk about preoperative therapy, because we tend to do that at MD Anderson. And the question is, what is that all about? I did tell you that the standard of care for operable pancreatic cancer is surgery first. So what is preoperative therapy? That is giving treatment before surgery. So the question is, which patients are good candidates for this approach? So the traditional approach is you take a patient who has operable cancer, offer surgery, and after surgery offer adjuvant therapy. The preoperative approach is to give some of this or all of this therapy before surgery and then operate. There are few rationales for considering this approach. One of this being that delivering multimodality therapy to all patients with operable cancer early on instead of after surgery may be important. If we have effective therapy, this may be even more important down the line. I told you when I started with the first slide that for most patients, the disease does tend to be systemic, and patients who recur tend to recur outside the pancreas, which suggests that there is micrometastatic disease and will be benefit proceeding with chemotherapy first if there is microscopic metastatic disease, and then do surgery last. We, of course, want to avoid surgery in a patient with rapidly progressive cancer. By that, I mean if a patient starts with chemotherapy and the next scan in a month shows a spread to the liver, it's not that we miss the window for surgery. I do tell my patients it's not that if we had operated right away, we would not have seen that. Unfortunately, if such a patient had gone through surgery, a month later, the next scan would have shown the liver metastases. And we've really not helped our patients with such a difficult surgery to proceed early on if there were any concerns. This is specifically true especially true when the tumor marker is very high, the CA19-9. It's a tumor protein in the blood. We look at that. If that is in the thousands, then it's important we put on our brakes and think about, could there be any microscopic metastatic disease we're not seeing on the CAT scan? It's also important to observe tolerance to therapy, which helps us predict tolerance to aggressive surgery. If we have a patient on a preoperative protocol and the patient gets one dose of chemotherapy and has a very rough time, it does suggest to me that we may have to work very hard at the patient's endurance and ability to handle an aggressive surgery. And finally, chemotherapy and especially radiation in the preoperative setting can help improve a negative margin resection. We do not have a randomized trial today to answer this question, but these are the rationale points that we think of as we plan our preoperative programs. We've done several such trials, and this table lists a few. Looking at the last two, which had a total of 120 plus patients, the median survival giving a preoperative program of chemotherapy or chemoradiation had median survival better than historical controls. So I had shown you in the previous slides that the median survival is in the 20 to 24 months. And using a preoperative approach, less patients did go to surgery because of an aggressive biology, but those who did go through surgery lived longer. So the average time between the start of therapy and surgery is about 3 to 4 months, and it's rare to see local progression during this time. Patients who are deemed unresectable after preoperative therapy are unfortunately those with distant metastases that you see on the next CT scan at the time of surgery. A few words on borderline operable tumor. I had mentioned earlier that 5% of patients are in that category between operable and completely inoperable. So to show a cartoon here, a typical borderline resectable tumor is the one that involves part of the artery. So the cancer is touching the artery here, and there's a concern that there will be a margin left behind that will be positive. If we proceed with the surgery first approach, not good. We do have data to show that the survival of patients where the margin is positive, R2, is not different from patients with locally advanced disease. So our internal schema for patients with borderline operable tumor is to proceed with a good 2 to 4 months of chemotherapy, chemoradiation. In this phase, the patient gets 2 additional CT scans, which also increases our confidence that there is no metastatic disease outside the technically challenging tumor that the surgeon needs to remove. And after surgery, we sometimes give additional adjuvant therapy, but most patients have received all the therapy before their surgery. This is a cartoon of a borderline operable tumor. Now, one thing to mention is that it's not that the tumor size always shrinks. Sometimes it does, but it's rare to see it shrink away from the vessel. And even though there is tissue seen right next to the blood vessel, what we are hoping for with the prolonged course of preoperative therapy is scar tissue or dead tissue that then allows us to still proceed with the same surgery. And the margin, when the pathologist is looking at this under the microscope, it is scar tissue and a negative margin. This is just an example to show you the sophisticated scans can really help us understand what changes are we seeing with chemotherapy, chemoradiation in the preoperative phase. This is a patient who has a borderline resectable cancer. The hepatic artery is encased in this case because you can see it up here and here. So it's almost a 360 degrees involvement of the tumor of the vessel by the tumor. And the patient underwent a prolonged course of therapy to suggest the same point again, where the tumor is smaller, but it's still close to the vessel. And we do not see it shrink away from the vessel. But this patient took preoperative therapy lasting 6 months, which allowed us to see the tumor reduction. There was a very nice decrease in the tumor marker that then did justify a complicated surgical resection with grafting with curative intent. Locally advanced pancreatic cancer is stage 3 pancreatic cancer. These are patients who have a tumor where the vessel is clearly involved to a point where you really cannot downstage it like a borderline situation. And we proceed with chemotherapy for several months, and in select patients, proceed with chemoradiation. There's a lot of interest in understanding the role of radiation therapy in locally advanced pancreatic cancer, especially after the LAP-07 trial. There was a small trial called the SCALLOP study, which looked at adding Xeloda, that's capecitabine, to gemcitabine. And actually, the pills with radiation did better than the chemo. But this trial is not what I want to discuss today. I want to just show you a slide or two on LAP-07 trial, because there's a lot of interest in understanding if radiation therapy is beneficial to patients with locally advanced cancer who are never going to go to surgery. Just before I do that, I want to show you a picture again of a patient with locally advanced disease. Looking at the cross-section, the vessel is 360 degrees involved with tumor right here, with a nice reduction, but unfortunately it is completely encasing the vessel, which does not allow grafting or surgery. And this patient did get chemoradiation after months of chemotherapy. So the European trial was done in 442 patients with locally advanced pancreatic cancer. These patients had a good performance status. They had some symptoms, but they were able to take care of themselves and get onto a research study. And without going into all the details of what R1 and R2 and the statistics are, the point I want to make is patients got chemotherapy, followed by more chemotherapy or chemoradiation after 2 months. And the study showed that there was no difference in survival. The authors concluded that administering chemoradiation is not superior to continuing just chemotherapy in patients with controlled locally advanced pancreatic cancer after 4 months of chemotherapy. CT is chemotherapy. This was a European trial. They tend to use less radiation than in the United States. And I think we would like to ask and answer this question definitively. More importantly, what we do need to do is understand if there are any predictive markers, whether in tissue or in blood, to get a better feel for which patients might be candidates for radiation or no radiation. Because in all these studies, it's all comers. All patients with locally advanced cancer are enrolled. But we know from experience that in some patients, the cancer metastasizes, and in some patients, the cancer stays locally advanced and contained. So how do we predict before it happens that this cancer will stay contained and this cancer has a tendency to spread, so let's avoid radiation? So the groups are working very hard to understand what are these predictive markers. One example of such a biomarker is called SMAD4, S-M-A-D, SMAD4. And there's some very early data to show that if you're SMAD4 intact, then there's a chance that the cancer may be more contained versus SMAD4 deleted, where there could be a tendency for spread. So trials that are based on such predictive biomarkers is the next generation trials that we need to do instead of all-comer trials, which can then help us sort out for each patient what's the personalized approach. The last section of my talk is on metastatic pancreatic cancer and clinical trials. Before we go into the details of treatment options available today, one of the reasons to understand why is it so difficult to treat metastatic pancreatic cancer compared to breast cancer and the progress that we've made in colon cancer is that it is rather chemotherapy and radiation therapy resistant, because there is no one mutation that we can tackle easily. There are many core signaling pathways that are quote unquote on in a metastatic disease, and even between tumor spots, liver versus lung versus peritoneum, there could be different signaling pathways with enormous amount of crosstalk that could be ongoing. So how could one drug or two drugs together inhibit all this crosstalk? For most patients with metastatic disease, chemotherapy, or rather systemic therapy, is our best approach. As mentioned earlier, the patterns of spread are in liver, lung, peritoneum, and we do scans every 2 to 3 months to follow up on therapy options. The first trial that was done that approved a drug for pancreatic cancer was in 1996. Gemcitabine was FDA approved for the clinical benefit response, which means that patients who took gemcitabine felt better. They had less pain, they gained weight, they had a better sense of well-being. So not so much for the overall survival benefit, but for the clinical benefit response, gemcitabine was FDA approved 20 plus years ago for for 20 years ago for treatment of pancreatic cancer. Since then, we have added other drugs to gemcitabine. So it's been gemcitabine for plus X or gemcitabine plus Y, and there have been many phase 3 trials, but very, very few have shown benefit. Now, this trial with gemcitabine and erlotinib did show a statistically significant improvement with survival. Erlotinib is an EGFR, epidermal growth factor receptor inhibitor. It's a pill, and it's given with gemcitabine. In this phase 3 study, there were many patients involved, and the benefit of gemerlotinib, the green line, was 2 weeks overall to gemcitabine alone. P here is placebo. So there was interest in the research community to understand in which patients gemerlotinib could be beneficial, but definitely not as much improvement as we would have liked to see. So there is a statistically significant improvement, but not clinically significant. There is a small group of patients with gemerlotinib who get a bad rash. It's like an acneiform rash on their face and upper torso. And patients with a significant rash, a grade 3 or 4 rash, tend to have a much improved survival compared to those who have no rash or only a grade 1 rash. And there's a lot of interest in understanding what are the predictive markers for patients who get the rash and may actually have an improvement with this combination, as well as could you give more of erlotinib if it's handled well to get the rash, and is there a way to know beforehand which patient may get a grade 3 rash, which could then suggest as a surrogate benefit. The regimen that is now considered frontline for pancreatic cancer is FOLFIRINOX. This is a busy slide, but I wanted to show you that this combination has been in use for about 2 years now. And there was definitely a nice green signal from the randomized phase 2 study. FOLFIRINOX was compared to gemcitabine, the F versus G, and there was definitely an improvement, which then led to the phase 3 trial comparing FOLFIRINOX to gemcitabine. This is 3 drugs. O here is the oxaliplatin, I is the irinotecan, 5-FU is a chemotherapy, and LV is just a leucovorin, it's a vitamin. So there are 3 chemotherapies given together, and it was compared to gemcitabine. There was a concern for toxicity, and I wanted to just point out a few things here. The grade 3-4 toxicity with the FOLFIRINOX arm in this study was significant for fatigue being much worse compared to gemcitabine, and clearly the neutropenia, which is drop in blood counts, and febrile neutropenia, which is low blood counts needing hospitalization, was also significant compared to gemcitabine. But more importantly, or as importantly, is that the overall survival with FOLFIRINOX was almost 5 months better than gemcitabine. The response rate was also significant compared to gemcitabine. So we are all concerned about the toxicity because quality of life is very, very important. And we have learned to tweak the doses of these drugs so that we can get the maximum efficacy without affecting toxicity or with minimizing toxicity. We are still learning. The regimen has been out there for 2.5 years, but there is some data being collected from single institutions and other groups that by giving less of the dose, we may not affect efficacy negatively. It's very important to follow all the toxicities on this regimen. It's given every 2 weeks, but we see our patients every 2 weeks. Some of them need to be seen on a weekly basis, and it is important to follow patients who have metal stents or plastic stents on these combinations because of the low blood counts. And sometimes the regimen may need to be moved every 3 weeks, just based on how they're handling it. So having a good feel for what to watch for, and the patients need to be very, very open discussing some of their symptoms, nausea, fatigue, so that the doctors can then drop the dose and add supportive measures as needed. Moving on to another regimen, which has just been approved in September of 2013, nab-paclitaxel was approved in September by the FDA for pancreatic cancer treatment for metastatic disease. This study was done in 842 patients, and the combination of gemcitabine and nab-paclitaxel was compared to gemcitabine alone. The primary endpoint was overall survival. And looking at the safety profile again, there was less febrile neutropenia and less fatigue compared to the FOLFIRINOX when you compare it to gemcitabine alone. But definitely peripheral neuropathy is something we watch for. Patients have numbness in their fingers and toes, and we ask them about that each visit if they're on this regimen. One important thing to mention is that 44% of patients with peripheral neuropathy resumed nab-paclitaxel after improvement in the neuropathy, and the median to improvement was about 1 month. With this combination, gemcitabine and nab-paclitaxel, the overall survival was 8.5 months for metastatic pancreatic cancer compared to single-agent gemcitabine, 6.7 months. And the response rate was also significant, 23% compared to 7% with gemcitabine. So what I wanted to just show you with the two different regimens is that we have options beyond single-agent gemcitabine or gemcitabine and erlotinib today. We did not have this 2-3 years ago. So it's definitely progress, and we need to build on this continuously. So clinical trials are very important, and the two regimens we have today came through phase 1, phase 2, and phase 3 and survived the primary objectives of these trials to move on and now become standard of care treatments. There are several phase 1, 2, and 3 trials for pancreatic cancer that are out there, more of phase 1 and 2, very few phase 3. So a typical phase 1 trial, a traditional phase 1 trial, is a one where the experimental drug is tested in a small group of patients, usually for the first time, to determine safety and side effects. We do gain and learn something about the effectiveness, but not much. The trial is then taken to phase 2 to a larger group of patients to determine effectiveness and to monitor the side effects. It's the phase 3 trials where the experimental treatment is compared to the standard of care. The last two that I showed you, FOLFIRINOX, was compared to the standard of care gemcitabine. Nab-paclitaxel was compared to single-agent gemcitabine. And if these trials are positive, they then change the practice patterns and change in standard of care. There are many novel targets that we are looking at for metastatic pancreatic cancer. KRAS has been important for 40-plus years. We do know that 90+% of patients with pancreatic cancer have a KRAS mutation. If all patients have KRAS mutation, it must be a very important oncogenic signal in the cancer cell. And we need to find a rational therapy to work on this mutation. So what happens is that with the KRAS mutation, the RAS signaling function is turned on all the time. So we need to learn how to turn it off. And there are a number of companies as well as NCI that are investigating ways to block KRAS. There is also a lot of interest in looking at immune checkpoint blockade drugs. And these are drugs that harness a patient's own immune system to treat cancers. If there is a positive signal, there might be ways to add it to chemotherapy. Additionally, there is an interest in insulin growth factor receptor and Notch signaling, c-Met, AKT, and PI3 kinase. Some of these drugs are out there undergoing studies in other cancers, breast, colon, and we may learn from those cancers and incorporate some of that data for pancreatic cancer over the next several years. But the challenge going ahead is how best to combine these drugs with minimal toxicity, because you can't just take 4 drugs and say, okay, this will block all the signaling pathways and we can just take them together, but it could be very, very toxic for our patients. And then how do you determine which ones of these are going to be beneficial? It requires us to go back to the drawing board and ask the basic questions and do more animal studies and very early work on tumor tissue, and then choose the best trials for our patients that are safe but are going to be helpful. Before I close, I would like to mention about symptom control. It is very important to communicate with your healthcare team. Patients have nausea, fatigue, constipation. Sometimes the understanding is I'm expected to have that symptom because of metastatic disease or chemotherapy. But there is a domino effect. For example, if one sleeps poorly, one can get up with nausea and fatigue, then you don't feel like eating. Poor appetite can allow for less fluids, which can make one more constipated, which can worsen the pain. So do have an open conversation with your healthcare team about symptoms so that the team can help understand whether it's a side effect of treatment or a symptom of cancer. We have many supportive care options available to improve quality of life, and that is so essential and should be done in parallel to active chemotherapy management. So in summary, I would say pancreatic cancer is a local disease and a systemic disease. It's essential that accurate staging is done up front, and especially when surgery is being considered, one should not make a treatment decision in haste. It's important that the surgery is done in a high-volume cancer center with multidisciplinary teams that do this on a regular basis. We have more options available with approval of new drugs in the last 2 years, and the research teams are working towards personalizing therapies and trials to match the patient, whether it's biomarker to understand which cancer is localized and which cancer may spread, and role of radiation therapy or novel targeted therapies for recurrent disease. We do have a long way to go, but we are definitely making progress. Thank you so much for your attention.
And Doctor, we have quite a few questions, and the very first question that we have for you is nab-paclitaxel the same as Abraxane?
Yes, it is. Nab-paclitaxel is the generic name for Abraxane.
Okay, and the very next question we have for you is, how does a patient know that they are getting a high enough resolution CT scan to be useful?
That is an important question. Most scans that are done in an emergency room may not be very high resolution because it's a quick scan done to look for a very acute issue. So if the patient has gotten a scan in an ER, it may not be high resolution, but I think it could help if you're just getting an elective scan to ask the healthcare team whether the scan is optimized for a pancreas protocol. So it's a scan where the cuts are very, very thin through the pancreas. So one thing to ask the team is this a multi-detector CT scan and 16 slice? And the second thing to ask is the scan and the contrast optimized for pancreatic cancer visualization?
Thank you, Doctor. And the next question is, what could be the reasoning why an oncologist would elect not to do post-op chemo?
Usually it is because the patient may not tolerate therapy. So there are at least 3 or 4 reasons. The most common is safety. If the patient has had a very hard time with surgery and a long time has passed, 3-4 months, an oncologist may not feel comfortable proceeding with adjuvant chemotherapy. 2, it might be the pathology, where all lymph nodes are negative. It's a microscopic focus of cancer, and there is no data on adjuvant therapy helping such a patient. Another reason could be that there might be certain host-related factors that the patient's nutrition is so poor that taking chemotherapy could add to more nausea, vomiting. So if the plumbing is not working well and there is a concern, the chemotherapy could make things worse. So I think looking at the patient's recuperation, pathology results, and post-operative CT scans are important, and those are the things that help an oncologist make a call.
Thank you. And the next question is there any trials that a person can join for stage 4 testing?
Stage 4 testing. So what I think you might be asking is for stage 4 pancreatic cancer, there are trials. It's overwhelming because there's so much information. One thing to do is to go on the PanCAN website, and you can actually contact the PALS program. You see that on this last slide here, and they can help you navigate to understand which trials may be suited to you.
Thank you. And the next question is, what is the status or outlook of the immunotherapy and post-op vaccine trials? Is that going to be discussed?
I'm not going to go into any detailed discussion right now because it's so early. There are trials ongoing. There are immunotherapy trials with the immune checkpoint blockade, which have just started, and they are ongoing in several cancer centers in the United States. The post-operative vaccine trials are ongoing in some places as well. I'm aware of Hopkins. So it's early. We do not have all the data. But again, either through PALS program or other websites, you can get a handle on whether one can qualify.
And the next question, Doctor, is compared to other cancers, why hasn't there been more medical progress?
That is $1 million question. Definitely we need patient advocacy programs. We have a Pancreatic Cancer Action Network that's doing a wonderful job of increasing awareness. We need to continue working on that. So there are environmental things that we can make a change on, but more importantly, it's just the cancer that has been so resistant to treatments. There have been many trials over the last so many years, but they have been negative. And now we are coming around to understanding why is it negative. One of the hardest challenges we've had is access to tissue. For leukemia, you get tissue from the blood. Breast cancer, colon cancer, there's access to tissue. But for pancreatic cancer, it's so hard to get into the pancreas without causing pancreatitis and getting adequate tissue to look under the microscope and to do all the genomic and proteomic studies that are available today. But given that we have techniques that can work with small pieces of tissue now, I am hopeful that we can make more progress. So it is a big challenge for us, and we do need more novel therapies and access to tissue to understand this better.
The next question, Doctor, is there any information on why reoccurrence is quicker in some patients versus others?
That is a very, very important question. We do not have all the answers today. But again, accessing tissue of resected specimens may have clues hidden in them. So there are some trials that are looking at resected specimens of patients, which is the tumor that was removed, of patients who are cured versus those who had a recurrence in 5 years versus those who had a recurrence in a year, and to really understand from the resected cancer tissue whether there were any signals there that can help us predict this long before we plan the surgery. So a very important question. No answers yet, but working on it.
The next question is, do the results of chemotherapy apply to neuroendocrine pancreatic cancer as well as pancreatic adenocarcinoma?
They don't. And that's one thing I mentioned earlier on, that adenocarcinoma is a very different cancer from the neuroendocrine cancer. So everything I've discussed today is for adenocarcinoma. Patients with neuroendocrine cancer are offered non-cytotoxic chemotherapy. They have therapies that are everolimus, called Afinitor, Sutent, very different drugs. So no, not the ones I've discussed today. They do not apply to neuroendocrine cancer.
And the next question is, what's the difference between response rate and disease control rate?
Disease control rate includes stable disease. So when we say response rate, it is patients where the cancer has shrunk. There is a partial response and a complete response. That's the response rate. Disease control rate is stable disease plus partial response plus complete response. So it includes patients who have no change in the size of the mass, as long as it's not grown.
And the next question is, what role does diet play in pancreatic cancer treatment and cancer treatment in general?
That's a difficult question because I do not have all the answers. What I do tell my patients for pancreatic cancer and diet, it's a full talk on its own, nutrition and how to handle the various dietary options and role of enzymes. So in a few words, I can say that yes, it plays a role in terms of how one can improve on some symptoms and keep the weight on. But regarding macrobiotic diets and some dietary fads, I would say that there is no good data out there that there is any specific complementary dietary programs that I personally endorse.
Okay, doctor, we have time for one more question because we're really close to the top of the hour, and is, why doesn't markers and scans reflect the same info?
Markers are a very vague surrogate, and there could be a situation where the tumor marker could not change or go up even though the scans don't show a change, and that could just be the clone of the tumor cells that could be making or not making that tumor marker. So the tumor marker, the CA19-9 is what I'm referring to, can help us to a certain extent, but it is not the gold standard to follow to understand whether we are seeing an improvement in the cancer status.
And with that, the Pancreatic Cancer Action Network extends its appreciation to Dr. Varadhachary for her presentation and to their sponsor, OncoGenix Pharmaceuticals Incorporated. Once again, a copy of the PowerPoint presentation and a recording of this webinar will be available at pancan.org under the Educational Events page. You will receive an email after the webinar with a survey. Your feedback is appreciated. We have another free webinar scheduled for February 21st, 2014, Complementary Therapies. Registration is available on the Pancreatic Cancer Action Network's Educational Events page. If you have questions, please contact the Patient and Liaison Services Department at 1-877-272-6226 and ask to speak with the PALS associate. This concludes the webinar. Thank you for attending.